Next we have Dr. Aditya Pradhan, who will be talking about use of AMT in surface reconstructions.
Good morning, everybody, and thank you, Shoham and Scientific Committee, for this opportunity. So I'll be just going through certain clinical scenarios in which the application of human amniotic membrane has saved the ocular surface and mostly the sight of the patient as well. So I have no financial interest to disclose. So the first case is basically a young male who had an injury to his right eye with an iron chain while working in a workshop, metal workshop. And there was a full thickness corneoscleral laceration and a corneal repair was done elsewhere. But then the wound was found to be leaking in the early post-operative period. So they applied a cyanoacrylate glue and a BCL over the sutured wound. And then since the situation was not improving, he was referred and he presented to the OPD of the clinic with complaints of redness and DOV. So this was the presentation in which you can see this vascularized scar and a huge chunk of cyanoacrylate tissue adhesive sitting over the suspected perforation and a BCL in place. So this was the AIOC2024. So you can see the outline of the BCL and the glue is causing some shadowing, so we can't really make out what is below that. So we took up the the wound to be explored in the OR. Just I have a short video of this. So the BCL is now being removed. So the plan was to remove the chunk of glue and then see what was below it. So the patient was adequately counseled that he may need a fresh surgery or something else. So we were not sure what to expect. So once the chunk of glue came off, another thing in these things is whenever you are applying any form of cyanoacrylate glue, the layer should be as thin as possible. There is no point in giving multiple drops of glue to make a thick plaque sit over the cornea that is more prone to dislodgement when the eyelid movements happen. So one thin layer of cyanoacrylate glue is more than enough to seal the perforation if it is within that acceptable range. So here, after removing the chunk of glue, we saw a huge crater sitting below it. So the plan is to cover the crater with a circular patch of AMT and then again cover the entire surface with a larger AMT. So now we are just focused on this. So this is the freshly prepared human amniotic membrane which Soham has shown. So then you just anchor it to the A by interrupted sutures. And then a larger, this is again fashioned from the previous membrane. You can refine it, you can cut it freehand, whatever way you feel comfortable. Glue is definitely an option. If glue is not available that day in the OR, you can always apply suture, that is the best. Sometimes the patient tend to rub their eyes, especially pediatric patients, so you may end up losing the amniotic membrane totally. Then you just anchor this. The rest of the surface was, so that is why we have not extended the amniotic membrane beyond the corneal margins. This is an additional security measure. You could have managed with just one AMT, but then it's better that if you cover the earlier patch one as well. So this was on post-operative day 8. You can see the AMT has almost resolved, like sort of disintegrated because of the surface inflammation, but the ocular surface is stable. There is no active leak. This was about, you can see the evolution of the scar over time. This is after almost 200 days after now you can see more of the iris details. The pupil also can be seen in this photograph. So another lesson here, like Dr. Tuhin has shown before, that don't be in a haste to do any keratoplasty after such surgeries, because you have to give time for the cornea stroma to remodel itself. So once the remodeling occurs, you would be surprised at how much the scar reduces on its own, or it becomes at least lighter to permit some form of less invasive modality like trial of a rigid contact lens or a scleral lens. So if the patient is not willing or not affording a keratoplasty, you can always counsel them that they can try, or we can try a trial of contact lens, maybe the rigid ones or the scleral ones. So this is another video of showing the excision of giant papillae. We see these cases now and then. So giant papillae cause two issues, that is the mechanical rubbing of the cornea causes a shield ulcer on the surface. So this was a boy who had this huge giant papillae in both the eyes, and he presented with shield ulcer in one eye. So the plan was to cover the shield ulcer with this amniotic membrane and then go and remove the giant papillae. He had a previous episode in which a supratarsal injection of triamcinolone was given, but this papillae kept on recurring. So, and the shield ulcer, because there was repeated breakdown of the epithelium, he was having shield ulcer. So that the one way to resolve it is to remove the offending structure, that is these giant papillae. So here you can just excise the ones, you need not go very deep into the tarsus, that will cause severe tarsal scarring. The ones just which are on the surface, which are offending, you can just hold them with the forceps and just shave them off or remove them off with a scissor. The surgery can be cleaner if you have access to a radiofrequency cautery, which many of the oculoplasty surgeons use it. So you can borrow that instrument from them and then use this to cause a much cleaner dissection and less bleeding on the ocular surface. So whichever way you choose or instrument you have access to, you can just use that method, knock off the offending papillae, and then the raw surface which is created after this, you just apply a amniotic membrane. In the end, you can place a symblepharon ring over the surface just to create more space and prevent the symblepharon formation. Since these patients are mostly in the pediatric age group, you can also do a tarsorrhaphy so that the child doesn't end up rubbing the eyes and removing the AMT somehow. And a sutured AMT is more preferable than glue, especially in the pediatric population. Just skip to that. So in this eye, already the AMT has been done for the shield ulcer. It is just the continuation of the same. I think the AMT part is not in this, but yeah. After you achieve such a surface, you just apply the AMT as been shown in the previous video. Yeah, this is I have put the absorbable sutures, Vicryl. This patient had undergone a pterygium surgery elsewhere, maybe a bare sclera technique, there were no records available, and then presented to the clinic with this. So there was a full thickness corneal abscess where the pterygium head was supposed to be there, and then this scleral melt which was infected. This later proved out to be fungus. So now the plan is to fashion a Tenon's patch graft to apply to the area of the scleral melt, and also do a large diameter eccentric therapeutic corneal graft to take care of this corneal abscess. So now we are anchoring you have to try and thin out the scleral patch graft as much as possible. The conjunctiva was badly necrosed in that, so the problem was to how to cover this patch graft, because conjunctival advancement was not possible. This was very close to the nasal side, and pulling of that would have incited more issues, maybe restriction of the ocular movements. So after anchoring the sclera over the scleral patch graft over the area of melt, now we are going ahead and doing a therapeutic penetrating keratoplasty. The graft will be eccentric. And then the plan is to cover this exposed sclera with human amniotic membrane, since access to conjunctival tissue was difficult in this case. Also at the end, it's a prudent idea to perform a tarsorrhaphy. Because these eyes are prone to melt. There is always some form of ischemia which won't let the wound healing, proper wound healing to occur. So tarsorrhaphy gives a lot of benefit in which the surface is at least stabilized and the wound healing occurs. So now we are using the freshly prepared human amniotic membrane, and then we are covering this area, and then a tarsorrhaphy would be performed over this area just to promote the wound healing. So I thank Dr. Nibedita Das, my colleague in the cornea department. So here there was a cyst in which she has done a scleral patch graft. He has used glue and interrupted sutures. And now she will be using a human amniotic membrane over the patch graft. And whatever, as she has mentioned, whatever you can approximate with the available conjunctiva, you can do that. But since you have amniotic membrane, so you are not that much afraid of a melt. Thank you so much.